Well, hello there, everyone. Good afternoon and happy first day of March to you all. Welcome to today's Ieci Quarterly Health Education Forum, CalAIM and Medi-Cal, how new programs will impact providers and patients. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society, but I'm also here today with you as chair of the Ieci, or the Inland Empire Community and Health Initiative, a coalition whose mission it is to ensure that all families and residents have access to affordable, quality, and culturally sensitive health care in the Inland Empire, which includes Riverside and San Bernardino counties. And you can always find out more about Ieci on its website, ieci.org, and be sure to look at our Facebook page because we have lots of great announcements and updates on projects there. We do want to extend an enormous thanks today to the Inland Empire Health Plan, or Iehp, for sponsoring today's forum. And in particular, thanks to Advisory Council member Marcy Coffey, as well as to our returning board member, Kevin Mahaney, who transitioned into a new position. So he went off the board, now he's back on. So welcome back, Kevin. And of course, our special Iehp guest presenter, Shelly LaMaster. As we get started today, I want to welcome our full Ieci board and advisory council, our rural health task force, and our advisory task force. And I definitely want to acknowledge our consultant extraordinaire, Victoria Stephen, who's in a very bright, colorful blouse today. Victoria, I like that. You look nice. We thank you for all the great work you do, not only behind the scenes, but in front of the scenes. And you keep us all on track, and you keep our grant funding straightened out, and our sponsorships and all that. And you just do so much and juggle so much each day. So thank you for that. And you're helping a lot of people through what you do as well. I also want to do something really quick, and I want to extend a belated congratulations to our board member, Danielle Kelkenstein. We recognize, is Danielle on with us today? I can't see. Is Danielle on? Well, shoot. Well, okay. Well, we recognized Danielle at the May meeting, and she received her Doctor of Public Health last May, and we weren't able to catch her in person at that meeting. And so I was going to hopefully recognize her today. But anyway, in her absence, again, congratulations, Dr. Danielle Kelkenstein. And if she logs on, we'll kind of, if you'll indulge me, we'll do this again and congratulate her again. All right, we're looking forward to hearing from our presenters today about CalAIM, or California Advancing and Innovating Medi-Cal, a program with the goal of moving Medi-Cal towards a population health approach. It prioritizes prevention and whole person care and emphasizes a more equitable and coordinated approach to healthcare delivery. And it's really a way to shift the focus to quality-based outcomes, which interestingly enough mirrors the transformation that we're seeing with physician practices, medical groups, and providers across all levels, who now have a deeper appreciation for value-based care and better overall health for populations. One thing before I introduce our speakers, Edith, who is our very special friend and guest here today, joining us again with Covered California, wants me to remind everyone that for some of the enrollers who are on the line with us, you know, when you're speaking about maybe some of the challenges you've encountered or some of the frustrations with regard to Medi-Cal and the process, just let's, everyone, this is a safe space for everybody. So, and it's a respectful space. So let's be sure that we all stay very, very, you know, respectful and friendly towards each other, because I know sometimes we know frustrations can bubble over. So Edith just wanted me to remind you all of that, and she may address that a little bit more later on. But this is a friendly zone today. So thank you. But we also want you to be open and honest if you have concerns. So please know that. I'm going to introduce our three speakers right now, and then following their presentations, we'll take your questions and answers. So as you're listening to our presenters, please feel free to enter your questions on the chat feature on your Zoom dashboard. And then we will, after we hear our three wonderful presenters, we will have Edith provide some closing remarks. So we are going to start today with Shelly. I'm going to make all three introductions right now. We'll start with Shelly LaMaster, MSW, who serves as the Director of Integrated Care, Behavioral Health and Care Management for Iehp. Shelly joined Iehp in 2008. She is a social services professional with over 30 years of experience. She has a master's degree in social work and has worked in clinical as well as leadership roles in a variety of settings, including managed healthcare, public health, and community-based organizations. With an extensive background as a medical social worker, Shelly adheres to an interdisciplinary whole person approach to helping vulnerable populations, leading innovative care teams, building relationships, and leveraging resources to optimize the delivery of quality, accessible, and wellness-based healthcare and social services. Welcome, Shelly. We're happy to have you with us.
Thank you.
Next, I would like to introduce Hanna Kim, Lcsw, Director of Long-Term Services and Supports at Molina Healthcare. Hanna has extensive experience in the areas of clinical and psychiatric social work, especially in the context of managed care and Medi-Cal, having previously served as Director of Long-Term Care and Social Services at CenterMed and as Social Services Manager at Care First Health Plan. While at Care First, Hanna also worked as a clinical and psychiatric social worker. And prior to that, she was at the Los Angeles Metropolitan Medical Center in Los Angeles and was also the behavioral supervisor at Behavioral Intervention Specialists of Los Angeles. She received her degrees in criminology and psychology at UC Irvine, followed by her master's in social work, MSW, at the University of Southern California. Yay. Welcome, Hanna. Happy to have you here, Hanna. And our third presenter today will be Nadine Khan, Program Director for Enhanced Care Management at Molina Healthcare. Nadine has over 16 years of healthcare experience, 10 years being in managed care. Her previous managed care positions include Director of Complex Case Management, Director of Health Homes Program, and Deputy Director of Utilization Management. Nadine has overseen Medicaid, Medicare, dual, marketplace, behavioral health, oral case management, community connector, children's special health care, foster care, and neonatal programs. Her clinical bedside experience includes medical, surgical, geriatric, and pediatric oncology care. She's also a wife and a mother of two. Welcome, Nadine. We're also very happy to have you here. So, Shelly, we're going to turn it over to you and take it away.
Okay, well, thank you very much, Allison, and thank you all. I'm so honored to be here as part of this event, and so thankful that Iehp was able to sponsor this event. A special thank you to Marcy Coffee and Kevin Mahaney. Kevin, we're very glad that you are now working with us at Iehp. Thrilled about that, and I'm also thrilled to have our good partners at Molina here on this panel with me. It seems like Hanna, Kim, and we communicate maybe once a week at least, especially since the outbreak of COVID and then with CalAIM. So thank you, everybody. I'm going to go ahead and just give a little bit of background. Most folks here, and you know what, let me back up one more thing. This is March 1st. I want to give a shout out to all the social workers. This is the beginning of National Social Work Month. So kudos to all of my fellow social workers, all of those out there that truly make a difference every day in so many individuals' lives. Okay, with that, so a little bit here about a little bit of background about CalAIM. Most of you know this is the new and improved way of delivering the Medi-Cal line of business to our members, and really is a positive game changer for those individuals that are already receiving Medi-Cal. It's more of a streamlined approach. Definitely that whole person care is a huge focus on it. Having some, implementing delivery system and payment reforms across the program, and just overall improving the quality of life and health outcomes, and really being able to now zero in. There's a big emphasis now, of course, as you know, on those social determinants of health, which we've all known those get in the way of the folks that we work with. A lot of times those issues get in the way of them being able to properly manage and improve their health and as well as their behavioral health. So now we have some new tools as well as funding to be able to do that. We did launch, CalAIM launched on January 1st, 2022. Okay, next slide, please. Here we have listed the CalAIM, the main components, the components actually. We have enhanced care management, the community supports arm of it, long-term services and supports, long-term care, and then that dual eligible special needs plan, which here at Iehp, we have the CMC, it's converting in 2023 to the DSNP plan. Then we have the major organ transplants, which now, that was effective January 1st as well, is now a carve-in. So the health plans are completely responsible for the major organ transplants. And I have a couple slides on that as well. We have new carved-in geographic areas that we did not have in our coverage before, areas such for our counties, such as Trona and Blythe, communities which are in particular need of not only programs and services, but infrastructure as well. So we have that as well with this launch of CalAIM. Population health, and then of course that focus on full integration, that whole person care approach. Next slide, please. The core services of Ecm, we'll just go through these here. Of course, the outreach and engagement, the comprehensive assessment and care management plan, enhanced coordination of care, health promotion, comprehensive transitional care, member and family supports, coordination of and referral to community and social supports. As you know, the Health Homes program is the former program is now Ecm. This focuses on a very complex, very chronically ill populations. So this is very high touch, intense case management that we are continuing to provide. Next slide, please. Here's just a timeline of where we are and where we are going to be going. We went live, of course, January 2022, focusing on the homeless population. All ages are high utilizers, the adults, the SMI, SUD population, the adults, and then that post-incarceration population of all ages. And that for us was Riverside County only. Now our go live focus on January 2023 will be incorporating post-incarceration all ages San Bernardino County, and then those at risk for institutionalization and eligible for LTC, that long-term care piece. And then finally, the nursing facility residents who are transitioning to the community. Those will be wrapped in as well. Go live July 2023, there's the list you can see there. That's when the children and the youth are going to be incorporated more in a variety of populations, the high utilizers as well as SED, and then those enrolled in California Children's Services, CCS, and then finally those that are involved in the child welfare system, children as well as youth. Next slide, please. And then how to refer a member to Ecm for Iehp. If you have an Iehp member who you would like to refer, here are just some contact numbers that you can make that referral by our member services, of course, there. And then the provider relations group is always available to take any questions or referrals that you have, get you connected with the appropriate team. So again, we have the care teams. We have both Model 1, Model 2 care teams that are working with these populations, continuing to providing the same services that they were providing under the Health Homes program. Next, we go into community supports, I believe, will be our next piece. Iehp, I just, we were a little bit ahead of the curve. We had an advantage because a lot of these services that are offered under community supports, we had already been providing. So what's wonderful now about this is that now we can get reimbursed from DHCS for these services and then turn that money right back into providing more services for individuals and families. We've been in the housing space in particular since 2008. We had a goal of housing 350 of our members, which we met back in September 2021. So we've been doing that for quite a bit. We've also always assisted our members with home modifications as well as medically tailored meals. So as I said, this is not unfamiliar. These services we've always focused on that we've always had our eye on that social determinants of health piece and those things that do get in the way of our members being able to take care of themselves and their families, particularly their health and their behavioral health, when those basic needs aren't being met. So community supports, as you know, these are services or settings that the plans we can offer, in place of, services or settings that are, ordinarily covered under the Medicaid state plan. They need to be medically appropriate and cost-effective alternatives. Now, cost-effective is always, that's one of the challenges that we're finding. That's always difficult to define. How cost-effective is it? Because you have cost-effectiveness in terms of what a service costs, and then looking at readmission rates and such. But then you also have that qualitative piece that, how do you put cost-effectiveness to quality of life? It may cost a lot to provide these families with what they need, but what you get in the outcome with the quality of life, so we do have some challenges of like, how do you measure that exactly? So these are things that we are working on as this program goes. And truly, and I know my fellow, colleagues from other health plans, this is pretty, we all feel like we're flying this plane, or building this plane rather, as we're flying it, and we're learning more every day. We're 2 months into it and we've received over 800 referrals. So that's pretty exciting for us. We're very thrilled with that. And then finally, we built our community supports program. It's technically not a Medi-Cal benefit right now. We anticipate that it will be. So we really did build our program for that, anticipating that, so that it could be an easier transition. We'd be ready for that already. So we created criteria for each of those community support services so that it can go through that process. Our providers rather, are able to submit the referrals for these services through the provider portal. And then we get most of those 812 referrals that we have as of this morning, majority of those are coming from our internal business units. We're getting more providers referring, and we're working on more outreach to the providers so that they are well aware of the services and able to make those referrals. Next slide, please. A little bit of a lag here. I believe it will be the list of the community supports that we are providing. There we go. We elected to launch 11 of the 14 DHCS approved community supports. Listed here are the 11 that we did go live with in January 2022. The majority of our referrals, as we suspected, are in the housing space. So that those housing suite of services there, the deposits, the transition navigation services, and the tenancy and sustaining services, which is really that daily ongoing care management for those members that have been placed in permanent supportive housing. As you know, it's very difficult for folks who were currently, or previously homeless, and then they transition to permanent supportive housing. If they don't have those wraparound services, they're not going to be very successful in sustaining their housing. So we have that service there in place for that reason. Recuperative Care is another service. We've been in that space for a very long time. We contract now with 4 providers to provide recuperative care. We've been doing this, oh gosh, probably since about 2016, I want to say we've been doing recuperative care. So that is not a new service to us. Sobering Center is very new to us. Right now, we unfortunately only have it available in Riverside County, but we're working with our San Bernardino County partners, as well as Loma Linda, on working on getting that service available in the other county as well. And then the environmental accessibility adaptations, that's a fancy way of just saying home modifications. Again, like I said, we've been doing that for a very long time, but again, now we can get reimbursed for some of these items that members aren't able to get. They weren't able to get through Medi-Cal, such as the life alert systems and some other things, the ramps and the grab bars and such. The meals, we're doing the asthma remediation. We're very excited about the asthma remediation and working on constructing a pilot, looking at our admissions and readmissions for asthma, looking at the kids that are being admitted with the asthma conditions. We have health navigators that work out in our school system. So we're looking at building a pilot around that and then tying that into this particular community support service. And then finally, the nursing facility transitions to assisted living or RCFEs. This is another service that we have been doing for a very long time. And actually our long-term care and our utilization management department, to date, they have transitioned back out in the community from skilled nursing facilities around 470 of our members, which is fantastic. And that's just life-changing for those individuals who, they did not have any options they felt or knew of to move back out into the community. But our team was able to assist with that with some partners and community partners and wrap those services around them. And we continue to do that to this date. And then next slide, we have effective the January 1st. Again, this is when we went live. This is a way that you can refer our any members or IHP members or patients that any of you are working with to community supports at Iehp. For our community partners, you could go ahead and contact our Iehp member services. There's the 800 number there. And then patients or members who are presenting in the emergency room who may benefit from community supports, you can call our provider call center. The first bullet there, this is for our hospital and facility partners, the members who are already inpatient, admitted into a facility. You have an Iehp concurrent review nurse assigned to that facility already. So we would like those partners to work through our nurse on the discharge planning. They will work closely with us on any needed community supports to help help plan for a safe discharge for these members. Next slide, please. I just wanted to say one thing that I neglected to say is that in January 2023, we're looking to add the remaining 3 community support services, and that's the personal homemaker services, the respite care, and the day habilitation. So we are looking at launching that next January. This slide talks about the major organ transplant. As you know, effective on the 1st, that was the other huge change, is that now that's carved into the managed care plans to be responsible for the organ transplants. So this is a list of the different transplants. And then we also are responsible for, providing those wraparound services and helping with transportation and meals and housing, and also services that any living donor might be in need of too. We are responsible for assisting with that care coordination as well. Next slide. This was the APL that was pertaining to the major organ transplant. These were the specific, the major changes. The referrals will be sent to us. There's a 72-hour turnaround time for the decisions for the evaluation and surgery authorizations. The key thing is that now members, whereas before they were disenrolled, now they will remain enrolled with Iehp throughout the entire transplant process, which is wonderful news, because that will provide or allow for that continuity, that tight wraparound with these members and their families to support them through the entire process and post-transplant. So that's really a wonderful thing. All the procedures must be performed at a Medi-Cal approved center of excellence. And then note there, the kidney, cornea, bone marrow, those are to be performed at CMS accredited facilities. And then the pediatric transplants, nothing new with those. Those still need to be performed at a CCS approved facility. Next slide, please. And then finally, here's the list of the approved facilities that we are collaboration with. So that, that is an overview of the services that we're providing here at Iehp. I know we're going to be addressing questions at the end, so I will hold off on entertaining any of those right now, and so I don't take up any more time from my colleagues. Thank you very much.
Thank you so much, Shelly. That was fantastic. We appreciate that. So, all right, next up we have Hanna Kim with Molina.
I'm actually going to, can everyone see my screen here?
Yes.
Presentation? Okay.
You
All
see
right,
your
wonderful.
screen. Wonderful. We're going to have Nadine right now.
We switched it up here. Keep
Want to
it
make sure
exciting.
people know it's you.
Trying to keep it exciting today. That's right.
That's right. It's a test.
Yeah. So Shelly did such a wonderful job in explaining our CalAIM. Because our programs we're following state guidelines from the health plans are, some of the information that we have are duplicative. So we'll speak to them from maybe a Molina operational stance. We did go over what CalAIM is. So we have the definition here and what the goals are of the program. So definitely, promoting these programs that are whole person centered, meeting the members in the community where they are, addressing those social determinants of health needs. So the person can focus on their healthcare needs. Okay, and initiatives that went live on 1/1 as discussed previously, but we'll go over them in detail here. So for enhanced case management on the Molina end, we did just want to discuss that we do still offer from the case management side our internal case management program. So Molina, we still have our basic case management teams for members who require sort of that medium need of assistance. Maybe they just need assistance with connecting to providers or some light education or assistance with some medications, short-term case management needs. We'll still continue that program. We will still continue our complex case management program that's internal, which follows our NCQA requirements. These members, maybe they have a new diagnosis and they need assistance with education, finding providers, medication reconciliations, D&E needs. These members may stay in the case management program a little longer. We will continue the complex case management program. Our enhanced case management, this is the most intensive of our programs. So we are identifying these members and identifying those populations of focus for the ECM case management program and partnering with our community organizations to assist those members in the care that they need. That's the biggest difference here. So social determinants needs that we are meeting the members in the community to really address their social determinants of health, so then we can move forward with addressing healthcare needs. A little bit more about ECM. So we did go over what the definition of ECM here, but I do want to point out here that it is building off of the previous Health Homes program and whole person care pilots. So members that were actively in those programs and pilots or in the outreach process for enrollment into those programs, they were grandfathered into the ECM program as of 1/1. We did go over what the framework of the program is, but here again, it's that whole person care, interdisciplinary, team-based, coordinated wraparound services, focusing on physical, mental, behavioral, social needs here. So it's really that wraparound care that is the expectation for the ECM program. I do want to point out, we talked about the Molina case management programs continuing. However, if a member is in one of our Molina case management programs, they are not considered for the ECM program. The ECM program is considered duplicative of our programs, of our internal programs. In addition, here, this slide is helpful. There's a lot of blue going on, but programs that are listed in this sort of light blue shade are considered non-duplicative and sort of enhances the other program. So a member could be part of ECM and a part of those light blue programs. This medium blue color, members are not to be in both the ECM program and the other program at the same time, but they may be appropriate for either or program. And Medi-Cal beneficiaries that are participating in the darker blue program, those members are to be excluded from the ECM program. Those members are not part of our populations of focus for the ECM program. And we will share this information so you have this after the presentation. So we did talk about those populations of focus. So as of 1/1, we did go live with individuals experiencing homelessness, high utilizers with frequent hospital or ER visits, individuals with SMI or SUD, and then individuals transitioning from incarceration, which is specific to Riverside only. And like Shelly said, in 2023, there will be additional populations of focus going live that will include those youth populations. For members under that population of focus of homelessness, these members would have had a complex condition and inability to successfully self-manage. So these are members with coordinating care and services and assisting in that homelessness aspect. Then we can focus on decreasing utilization, increasing that more medical condition need for those members. DHCS has a very specific definition for homelessness. So when looking through our internal population of members, we are following and looking for members meeting this definition. For high utilizers, we are looking for members having 5 or more emergency visits, or 3 or more unplanned hospital admissions, multiple short-term skill stays, or any combination of those where appropriate outpatient care would have prevented those visits. For our members with serious mental illness or substance use disorder, we are looking for members who meet the eligibility and they're obtaining services through county specialty mental health or the drug Medi-Cal organization delivery system. We are looking for members actively experiencing one complex social factor that's influencing their health and meeting one of the following here. So their health risks, they're high risk for institutionalism, high risk for ER use, multiple ED visits, hospitalizations due to the SMI or SUD, or they're pregnant and postpartum, including up to 12 months from delivery. And for Riverside, we do have our youth and adults transitioning from incarceration, and that they're meeting one of the following conditions here. We are looking for within our population and identifying those members for the ECM program. And as I briefly stated earlier, members who were part of that Health Homes program and the whole person care pilot as of 12/31, if they were enrolled or in the process of being enrolled, those members were grandfathered into ECM as of 1/1. So to continue their care. They were grandfathered into the program. Within 6 months of being grandfathered into the program, they will be reassessed at that time to see if they meet the 4 populations of focus for the ECM program to continue the ECM program. If they don't, we'll take a look at them for our internal Molina case management programs. Okay, with that, I'll hand it over to Hanna for community support.
Hi, everyone. Shelly went over quite a bit, so I'll go at it at a high level and just a little bit more specific to Molina. And as mentioned, DHCS actually doesn't consider the community supports as benefits. They term it as services. However, as Shelly mentioned, we know the intent is to really for the state to be able to evaluate which of these community supports would be adopted as Medi-Cal benefits. So we're really excited, and just echoing Shelly's excitement as well, that for a lot of these things, Molina has been providing us for some of these CS. And so it's just really exciting to be able to do this on an official note. And just a word of caution, I unfortunately have gone in a habit of calling community supports as CS. So I pardon the acronym. I will try to catch myself as often as possible and correct it. Next slide, please, Nadine. Thank you. So as mentioned, this is the full 14 menu of CS of community supports. However, for Molina, next slide, please. We're really focusing on 9 in Riverside County and 8 in San Bernardino County. And the sole reason for that, for the differentiation, is unfortunately just because in San Bernardino County, right now, a sobering center does not exist. We were very, very lucky and very excited that Riverside University Health Systems opened one just last November. And so we've been talking to them on a regular basis along with Iehp, and really looking at that ongoing and new partnership that we have with them. I'm gonna just really at a high level go over just really one sentence per CS, just to kind of reiterate a little bit what the intended reason and for whom it would be intended for. Next slide, please. But just to start off for Molina, our eligibility criteria focus are those with Medi-Cal only and partial dual members, meaning that they have Medicare Part B and or D, and then Medi-Cal as well. And for Molina, it is a slightly different process. And I apologize for that differentiation between the two. We have referral forms. The link is in our PowerPoint. It's on our provider website as well, at molinahealthcare.com. And any referral form that's submitted, that's completed, can be submitted to our community supports team so that we can review it for criteria, ensure that the members are eligible to receive that community support. Next slide, please. Housing transition navigation, as Shelly mentioned earlier, it's really for members who are experiencing homelessness, at risk of homelessness by housing and urban definitions as dictated by the state policy. And it's really trying to find someone experiencing homelessness or at risk of it to find new housing. Next slide. So we kind of consider this along the continuum of getting housed, and you'll hear through our discussions of CS, there are quite a few CS community supports that are dedicated and really focusing on those who are experiencing homelessness. So housing tenancy is really that natural continuum of the community supports. And as Shelly mentioned earlier, it's really because the state did recognize, and we recognize, that it's a really important factor to helping someone who's never been housed and has that wonderful opportunity of being newly housed, the importance of keeping that so that they're not experiencing or at risk of experiencing homelessness once again. There is a state restriction that it's only available once in a member's lifetime, and that is throughout their lifetime of being enrolled with Medi-Cal, regardless of which health plan they're enrolled with. Next slide, please. Kind of rounding out the housing, this housing continuum is this wonderful opportunity that health plans have, which is to provide financial supports under this community supports of housing deposits. And it is strictly only for those, again, who are experiencing homelessness, who need that once in a lifetime funding in order to obtain permanent supportive housing. So for example, like security deposits, or first and last month's rent. These are things that can be funded in order to really assist someone who's been experiencing homelessness get newly housed. It is unfortunately also restricted. It is a once in a lifetime, just like what I just mentioned for housing tenancy, regardless of which health plan the member is enrolled with, it is a once in a lifetime that community support is available for each member. Next slide, please. Recuperative care, just like Shelly mentioned, Molina actually, has been actually in this space for a number of years. We've also actually been providing recuperative care as what we deemed a pilot program. So it's really wonderful for us to be able to provide that now as a community support and really, under this official umbrella and with the state services. It's geared towards members who are experiencing homelessness as well, or at risk of experiencing homelessness, who need a stable environment to recover from a short-term illness or injury. And I really want to emphasize that latter part of recovering from a short-term illness or injury, because oftentimes there can be some confusion that it might be more like for shelter purposes. And as the name suggests, it's really for providing a stable environment for someone to recuperate. And there is a restriction as well that it can only be authorized for 90 continuous days. Next slide, please. Community transition services is also actually a case management function that we've been doing here at Molina for a number of years as well. Since 2016, we've been helping members who have been living in long-term care at a nursing facility who need assistance transitioning to a lower level of care in the community. And that's exactly what community transition is. It's about helping someone who's been living in a nursing facility for institutional care transition into a lower level of care in the community. It is also restricted to once in a lifetime, however, but also to add, there are some state waiver programs as well as state programs like the California Community Transitions program that would need to be utilized first before using the community support. Next slide, please. And I promise you we're almost there. I know you've been hanging in there for quite some time. I appreciate everyone's endurance of hanging there with me. Personal care. So that's something that Molina went on. We felt really confident. We've been doing personal care as a care plan option under the CalAIM Medi-Connect line of business. And so really it's to help someone who needs assistance and doesn't have supports in the home. However, they would have to meet 3 scenarios. The first is the member is newly referred for in-home support services and pending that IHSS case to be concluded and or finding a caregiver in that meantime. So it's really bridging that period of a member who's been newly referred for IHSS to get caregiving services in place while they're finding their permanent caregiver. The second scenario as well is that it's for someone who is already receiving IHSS and pending a reassessment. So perhaps they need additional hours, been a change of condition, unfortunately. The member is not feeling as well. They were hospitalized. Previously, they were walking. They were able to do most of their activities of daily living. And now, unfortunately, they're using a wheelchair. So that's also an opportunity that we can and now are able to use personal care community supports to help support a member from not being rehospitalized due to the lack of care in the home. The third, and which really excites me, is a member who's not eligible to receive in-home support services, and that is restricted at 60 days max by the state policy. And I just want to emphasize, this is a really exciting one for us. And I know with our Iehp partners, we have such a great relationship in our counties, and our counties have such, they value the collaboration and support with the managed care plans, that we have ongoing agreements to be able to really ensure that any barriers to getting the IHSS case resolved is done as quickly as possible. And so this really excites us, because we're able to really provide that extra level of support that some of our members might need that they previously didn't have access to. Next slide, please. Medically tailored meals is something that Molina also had piloted starting last year for our Medi-Cal members. And so this is something that we feel, really excited about. We see the value in it. And it's simple as any member who's been recently hospitalized or recently been discharged from having been admitted at a skilled nursing facility are eligible to receive up to 2 meals per day, up to 4 weeks per hospitalization or SNF admission. It is max per state policy at 12 weeks in a calendar year. Next slide, please. And I swear just one more after this. Sobering centers, as mentioned, it's only applicable for Riverside only. And we're really excited about our, pending partnership with Russ, and really, see the value of individuals sobering at a location, as opposed to, especially now with the public health emergency, going to an emergency room or needing to go to jail and using up spaces that we as a community really need to utilize for those in need. So it's really giving that opportunity of redirecting resources, so we can ensure that folks are in the ED getting the medical support they need, rather than just utilizing that time and space for sobering up. Next slide, please. Last but not least, asthma remediation. Also, as Shelly mentioned, really excited about this. This is actually brand new for Molina. And there is actually a current grant-funded program called the Asthma Mitigation Project that would need to be utilized prior to the community support. However, we see it's so valuable. We know there are so many individuals with poorly controlled asthma who could really benefit from these asthma remediation services and supports. And that is unfortunately by policy from the state restricted at once in a lifetime as well. But again, we're really excited as managed care plan that we're going to be able to take it a little bit step further outside of what we typically do as a health insurance plan. And that will sum up our 9. Yes, thank you for hanging in there with me. And I know Shelly went over a little bit about major organ transplants, but I will turn it over to Nadine and see if there's anything else we might want to touch base about that.
Yeah, so Shelly did such a great job at covering this program here. But we do, I do want to point out that for, oops, sorry, next slide, happy here. Okay, so with the effective date of 1/1, the program was carved in, meaning that the health plans can provide those wraparound services, those case management needs, and really assist the member from evaluation through post-transplant, which is just such a wonderful thing for our members. So we're very excited to have that opportunity to provide those services and case management programs to the members in this time of transplant in their life. So often we have in our case management program sort of assisted the members in their transplant journey up until it's really time for them being approved for a transplant, and then we can no longer assist. They're disenrolled to the state. So we get to assist now and really see it through the entire transplant journey with our own members. So we're very excited to continue that case management and relationship with our members. Here are the major organs that are part of the program with Molina.
And just something to note, since this is under the header of CalAIM, the Multi-Purpose Senior Services Program was also carved out from out of the Coordinated Care Initiative, also known as CCI. So I just want to reassure everyone, though, however, nothing has changed about MSSP itself, the criteria, the oversight. It is still being run by our 2 county partners, and we're very, very lucky, as mentioned, just with IHSS as well. For MSSP, we have ongoing agreements and coordination discussions. So really, it is part of CalAIM, but just want to share. I hope this doesn't alarm anyone because nothing has changed to the program itself.
That's right.
Next slide, please. And this is our referral process. As I mentioned, they would be submitted to our CS mailbox, and I will make sure, if it's not on here, to add the website for the public provider website as well, where all the referral forms are currently housed. And just something to mention as well for Molina, we do have HealthNet members that are delegated to HealthNet from Molina that would defer to HealthNet for those community supports in ECM as well.
Yes, and just to point out for ECM, we do, even though we do have a specific ECM referral, we will take referrals on any sort of form for ECM. The RCS referrals are very specific and should be on our Molina CS referral forms. However, for ECM, we will accept into our email inbox any ECM referral type. Okay, now we're at questions.
Okay, wow, you guys, that was just absolutely amazing. You are all doing such tremendous work in this space, individually as well as through your organizations. And I feel inspired by it. I want the world to know that you guys are doing a lot to really take care of our residents, you know, in this region and in California. So thank you. That was very, very enlightening. Okay, so Soteria would normally go through our questions, but Soteria, I had a couple of questions that were sent to me on the messenger, so I'm just going to get started and present them. Okay.
Sure.
Our first question is, San Bernardino County going to develop a sobering center, and how do persons released from incarceration obtain access to health and other services? So whoever wants to jump in on this, feel free.
I can address the sobering center piece because I know our chief medical officer is currently in conversations with San Bernardino County as well as Loma Linda. Like I mentioned, we also have one other CBO that is interested in providing that service. So we are continuing those discussions right now and making some final decisions on who we might be able to partner with for that. I think San Bernardino County, it may take a bit of time for them to be up and running. So that's why we're kind of hopeful that maybe Loma Linda would be in a better position to move quicker on that. So, but definitely more to come, and it's in the works for sure.
Yeah, and we would echo what Shelly says. In fact, it's, you know, we've been partnering and collaborating with Iehp on this. So it's really important for both Molina and Iehp to find a partner who really has that expertise. I think a lot of folks can raise their hand and say, I can, you know, develop a sobering center, but we want to make sure, you know, the state has within its policy a lot of language of ensuring that we're really partnering with folks who have that knowledge base. So it's really important to make sure that we develop those partnerships with that in mind.
Okay, fantastic. Thank you. Our next question here is, which community supports are the health plans finding the easiest, and the most difficult to provide for their members? Again, whoever wants to take that.
I can go ahead and start from our perspective. The housing suite of services have been pretty easy because, again, we've been doing that already. Particular services such as the home mods, that's a bit challenging because there is some documentation that has to be received from the provider. So as many folks know, often you get a referral from a PCP or a specialist and it just says, needs ramp, needs grab bars. And so then, we get the referral, and then the challenges are, because we're following a authorization process, our clock starts. We have to stay within a particular turnaround time. So we have to, what we're doing is actually we're approving a consult so that then we have some time to follow up with the referring source to get the necessary documentation that supports and satisfies the request for the particular home modification service. That's been a bit challenging to work out, because I don't think we've had one case where all the documentations come over with it. It's usually just a very simple request, but we've got to backtrack and do that. So I think for us, that's probably been one of the most challenging.
I think for Molina, probably the easiest is probably the meals. It's been something we've been doing for a pretty long time already. I'm so sorry if everyone can hear my landline. I still have a landline and it's ringing right now, so I apologize for that. But I would say the meals is likely the easiest. I wouldn't say challenging, but more so I think the confusion of personal care. Sometimes we'll get referrals that it's the misunderstanding of what is personal care and under what scenarios it's eligible. So that can be sometimes a little confusing, and those are scenarios that were proposed by the state as well. So for Molina, we adopted them because we saw that value, but it can be a little bit confusing because of that emphasis on the member has to have been referred to IHSS first.
All right. Okay, thank you very much. We have another one here. How will Molina and Iehp provide more services to children?
I guess we can continue with our rotation here. I'll go ahead and start. At Iehp, as I mentioned, asthma remediation is one particular area that we're really looking at utilizing that service, leveraging our health navigators that are already out in our school systems. So that's one area. And then with our CCS population, we already have the transplants that are provided through those providers already. That follows the same route already. We will be folding in more of the children's services, as you saw on that timeline, in 2023. But right now, I mean, there really is a focus on, at Iehp, we are working on developing a more complex children's model, if you will. And also in particular for youth, I mean, legally you're no longer a child once you turn 18, but those of us who are parents, we often know, or just our experience with youth, it's really, they're technically adults, but those young 20s, those kids, I still call them kids, they need assistance as well, navigating the healthcare system, behavioral health system, in particular foster care system. So that's another area that we're looking at really zeroing in on and seeing how we can beef up and wrap around better service for them, because once they age out of open access, foster care system, oftentimes, as you know, they fall through the cracks. And oftentimes they become homeless. They have other, financial challenges and things that happen to them, substance abuse, of course. So those are some examples of what we're looking at.
Yeah, just to piggyback off of that, in general, our case management programs, we do a lot of case management already for our youth and our pediatric populations. So much of our we do have a large population of pediatric members that are assigned to our internal case management programs. We also have foster care program, and part of that foster care program is a transitions out of foster care program in addition. So we sort of that transition, as Shelly said, so none of those kiddos fall through the cracks. We're assisting them. We continue to assist them with those, any conditions that they may have had in addition to being in foster care, assisting them in finding adult providers, and keeping them in our case management programs a little bit longer to keep an eye on them to make sure that they are stable and aware of how to navigate the healthcare system, right, which can be really tricky for any of us as well. So just making sure that they are supported. But like I said, like Shelly said, in 2023, we are expanding the official ECM, right, populations of focus, the state's expanding, but internally, as an organization, we do have many programs for the youth that we identify for our internal case management programs.
Wonderful. Thank you very much. We see your hand up, Dr. Sakira. Let me take Harris Koenig's question first, and since he jumped right ahead of you, and then we'll get to you. Harris Koenig, thank you. I'm glad you're on here today with us. And your question is, how does the Riverside Sobering Center operate in concert with the 911 response system?
I can go ahead and address what I know. So far, we haven't had any referrals for that. I did have a privilege of doing the virtual tour of that center. It's a fantastic center. I know they have done significant outreach with law enforcement. And, you know, we work closely with Riverside County law enforcement as well. So my understanding is that they have that collaboration going. The hope, of course, is that law enforcement, instead, that's the whole intention of a sobering center, is instead of taking that individual who's intoxicated over to the law enforcement center, the police station, what have you, or an ED, they can take them right to the sobering center instead. So I know they've made a lot of taken a lot of effort in making those services known and doing that coordination.
Okay, Hanna or Nadine, did you want to add anything or no?
No, unfortunately, Shelly actually got it and hit it on the nail.
Yeah, Shelly covered it. Great, wonderful. Dr. Michael Sakira is with us, our public health officer.
Thank you, and thank you for the great presentations. And so, first off, the emergency departments of San Bernardino County would like to thank you. They will be sending all of their sobering patients to Riverside County, since there's no need in our facilities. So that's just a joke, of course, but we I think we do have the expertise within our medical centers in Loma Linda and Arrowhead. So we look forward to doing that. My question really is, CalAIM is really, it was developed to provide for integrated holistic care to, people with multiple elements, in lieu of services, they call them, but basically all the social determinants of health. This population is by nature a transient population. If we look at the homeless people, the people who have multiple medical problems, et cetera. How do you integrate all these services, and how do you determine which of those social determinants of health each individual patient needs, especially when they reach different touch points? They come to one ER, another clinic here, so how do you bring it all together for the community and for those individual patients? I think that's the challenge. Is each of these patients have a different element. It might be a transportation element, it might be a food element, it might be a housing element, and or an access to care element. So.
Yeah, I think I can answer that to some degree for the managed care plans. We got a little lucky, I guess, in that the state already did the research They came up with the prescribed 14 menu of community supports ahead of time and then gave it as an option for each managed care plan to elect to decide when to implement them. They determined based off of their, assessments and analyzations that these were that in lieu of service at cost-effective community support, that was also addressing that social determinant of health. And as you've seen through our presentations, that a large number of them are really geared towards individuals experiencing homelessness. And really the focus of so many is to really obtaining that housing and then sustaining that housing and infusing the tools and the life skills into really being able to, stay in the community in a stable environment. So I do feel that with that incorporation of community supports and the populations of focus and enhanced care management, with that and really that increased support and all these folks who are going to have such high touch points with each individual, we hope we're very excited to be able to do this, to see eventual outcomes of improved health outcomes, improved quality of care, improved quality of life, period, as an individual is living in the community. Sorry, Shelly, really excited.
Yeah. Well, I'm going to give a specific example. You've got a homeless person who has methamphetamine and opioid use. He's found in Bloomington. Maybe he's anchored to Arrowhead Regional, but he's picked up and brought to Community Hospital San Bernardino. Where's his medical home? I mean, how is he brought back in to the system to evaluate his substance use issues, his psychiatric issues, his homeless issues?
So
how is that?
Yeah, someone who is already, meeting that SMI, SUD. Nadine had that slide up. I don't know if we want to pull that up again, if that'd be helpful at all, but that's a population of focus that I'm already seeing in my head. And sorry, my case manager mind is like going into overdrive now of saying, well, we've got to get him in that ECM pop. We have to, check that out. That's a right fit. If that's not, if that individual doesn't meet the full criteria, because unfortunately it can get very specific and detailed per the state policy, then folding them into our internal case management supports and seeing what other community supports or what other benefits or non-benefits can help support that individual.
Right. Well, that's where that interdisciplinary care team part of the program comes into play, right? That's why ECM is so important, because for so long with our own internal programs, we were only seeing a certain aspect of the member, very data-driven aspect of the member as well, unless we could get them on the phone and get some information from them. With this interdisciplinary care team aspect, we're partnering with our partners out in the community, to, find the member, get them enrolled, do some in-person interactions with them, get their PCP involved, get their behavioral health provider involved. Get the housing specialist involved, in addition to, our teams involved, and let's all work together in addressing that individual's needs. And each person sort of brings a different aspect of that member to the conversation. On our end, we can look and see what medications they filled or what providers they've been to. The housing specialist knows exactly the conversations that they had and where the member wants to be and the member's sort of habits. Where do they find them in the community or meet them in the community? If that ECM provider is their PCP's office, they also have a different aspect of the member that we all come together as that interdisciplinary team to really address all of the members' needs on the social determinants and the physical end.
I would just add, everything was very well said by my colleagues there. This relationships are so critical and can't overemphasize that enough. And and taking those extra steps to build those relationships with our facilities, the providers, the social workers, the care managers, the physicians, and have that ongoing dialogue. You know, we've been doing a lot of marketing to our facilities about CalAIM and the programs that are available, and, you know, looking at possibilities of doing business a little bit differently and having more of a presence at the facilities and working more closely together. But that's just, I think that's the only thing that, you know, I would add. That's just such a key component. Having that ongoing communication and networking is critical.
Yeah, I think that, and down the line, you know, what I had hoped to hear and envision was a navigator that is basically knows that patient, that there's a call system that, you know, this is a patient. Wow, we finally got him. We've been looking for him at community hospital. Let's get him, and now let's evaluate his needs and correct that. So hopefully down the line we'll be able to have a flexible system that allows for multiple points of entry and allows that patient to be integrated into that kind of care, because that's what we're seeing real time in the ERs. We see people that their primary care provider that works 9 to 5 in their one office is not going to be able to coordinate all that.
Yeah, agreed.
Wonderful. Thank you very much. All right, our next question here from Kara Knoll. Has anything changed with criteria with being able to provide housing services? We refer many patients for housing, but not all qualify.
Is this in particular for an Iehp question for our program?
Not indicated here, so I think it's for whoever.
Yeah. What I can speak to for our experience, prior to the launch of CalAIM, our housing program criteria was much stricter. We had limited funds. We actually used our own funds to help members with permanent supportive housing. So we had to have pretty stringent criteria. So we had set criteria up and limited it to those folks that they had to have had a 7 nights, didn't have to be consecutive nights in it for an inpatient stay, but during a 12-month period, because what we did is we calculated and figured out that 7 days in a hospital was equivalent to about a year's worth of rent. So we had that as one of the criteria, as well as a few others. So what I can say is with the launch of CalAIM and community supports, the criteria is much more open for us anyway. We don't have to have that 7 day stay requirement anymore. They have to meet the HUD requirement for homelessness, which for those that are chronically homeless, this is not difficult to do. So, and able to speak to that, I'd probably need a little bit more information about what the reasons were why the individual didn't qualify. But my experience is that most of the time that they do, if they are chronically homeless, then they most often do have the medical and/or behavioral health conditions. They're gonna meet the criteria, at least speaking from Iehp.
For Molina, and I see Karen already said that Kara said thank you, so perhaps I answer the question, Shelly. But just to emphasize, so the definitions for housing transition are anyone who's been prioritized for supported housing unit or rental subsidy through the coordinated entry system, anyone who meets the HUD definition of homelessness or at risk of homelessness, the HUD definition. And then there's an interesting 4th definition that the state created, that it's someone at risk of experiencing homelessness and they have a chronic condition or a serious mental illness, are at risk of institutionalization in ECM or ARTE, transition age youth. And I just want to add, perhaps also, this may not be the question, but may lead to a question someone may be thinking about, is that the transition from health homes program to enhanced care management, there were a little bit of a difference of eligibility criteria as well. So it did narrow it down a little bit differently, but then also almost in a way, expanded it because of the different populations of focus as well.
Great, thank you. Actually, we only have time for one more question, so I apologize. This is a robust discussion, so I'm glad that's a good thing to happen. Here's our question. How has Molina responded to the ACEs Aware work and Network of Care roadmap to develop whole person family care strategies, especially for maternal and prenatal health in partnership with community health systems? That's for Molina.
So I apologize greatly. Neither Nadine nor I are in our youth and children department of oversight. I do apologize for that, but we can certainly take that back if that person would like to list their question in the chat, and then we can know with whom to circle back to.
Sure, that's great. It was Dr. Wendy Lee over at First Five. So, but we'll connect you up. We'll make sure we get all those questions. But all right, so I'm sorry we have to move along, but we only have a few more minutes here. So really quickly, okay, is Danielle on the line with us? Yes, Danielle, we have tried to do this a couple of times and I keep missing you. So what I want to do is congratulate you. And let me just find my notes here to thank you. Okay, so we tried to do this last May, right after this happened in your life, and we missed you then. We tried to do it at the beginning of this meeting, and so you're on with us now. So we just want to officially congratulate you for your doctorate in public health, because you successfully defended your dissertation through Loma Linda University School of Public Health and earned your degree. So Dr. Kilkenstein, congratulations. And Danielle is one of our esteemed board members.
Thank you so much.
Thank you. All right, we now have our very special guest and good friend and longtime friend and partner of the Ieci, Edith Laura Trad, the Regional Business Representative for Business Development for Covered California. Edith has more than 40 years of combined experience in public and community relations, public health planning, education and administration, public speaking, and behavioral health clinical work. Prior to joining Covered California, Edith worked with the County of San Bernardino Public Health Department, where she served as the county's emergency public information officer, leading the communications for emergency events such as the H1N1 public health emergency outbreak. She also has a very long list of credentials related to her community work, her service on numerous boards, and her role as a consultant. Edith, it's always really nice to see you, and the floor is yours.
Thank you. It is a true pleasure to be here with all of you. And first of all, I'd like to, following the amazing presentation, I want to applaud the partners that proceeded during this presentation for the powerful information they shared, which this will improve the life and health of the Inland Empire residents. And along with that, as you know, Covered California is so happy and proud to work besides all of these partners. As you know, the Covered California mission is to increase the number of insured Californians, improve health and care quality, lower cost and reduce health disparities through an innovative, competitive marketplace that empowers consumers to choose a health plan and providers that gives them the best value. As you know, in Covered California, Covered California is a free service that connects Californians to brand name health insurance under the Patient Protection and Affordable Care Act. Covered California is the only place where you can get financial help when you can buy health insurance from well-known companies. We have about 12 health plans statewide 5 plans in the Inland Empire. We're proud to share some of the accomplishments that we have so far have with our previous or just recent past open enrollment, which ended in January 31st. As you know, open enrollment begins with renewals on October 1st of 2021 in this case, and ended in January 31st of 2022. And I have to say that it takes a village to be able to accomplish the numbers that I'm going to share. Not only am I proud to hear what our wonderful partners in the Inland Empire are doing to improve the quality health, but many of you that are listening are part of the accomplishments of Cover California. Some of you know that we have so far enrolled over 1,869 individuals. We have enrolled many individuals into Cover California. And what I wanted to share with you is some of the data of the individuals in the Inland Empire that also have been part of this process. What you're seeing here to your right is a slide that basically it gives you a significant information about who is enrolling and who is being part of this process. Obviously, some of the people that are listening are Cover California enrollers, and some of those Cover California enrollers have probably enrolled quite a bit number of this of the services that we are providing this year in 2022 related to health care access to our people in California. About 54% of the individuals that enroll, our partners that enroll, are actually agents, followed by 38% of folks that are enrolling through the website in Cover California. 4% of the people that are being enrolled are through the Cover California Service Center. 3% of the individuals enrolled were supported by certified enrollment counselors, which some of you are listening to this presentation. Plan-based enrollers, 1%, and eligibility workers that were also the county eligibility workers that also supported the enrollments. Here to the left on this slide, you will see the different information, the 2 different enrollments that we did between October and December. We did the renewals. The existing renewals went up to 1.5 million individuals. 86% of our enrollments went to renewals. And we did have people that came into Cover California, residents of California that came into Cover California for the first time, and we had over 14%, 2,889 plus individuals that came into Cover California. These are really huge numbers and I wanted to share with you these numbers because I think it's extremely important that you understand that the services that are being provided by partners throughout the state. These are statewide numbers, and I'm going to follow with the local numbers. During open enrollment in the Inland Empire, we have also a large number of individuals that were enrolled. Again, 173,000 plus that were enrolled through Cover California between October 1st and January 31st. The comparison is, as you see in the pie, very telling numbers and how we are enrolling in the Inland Empire. That's a huge accomplishment for those partners that are listening. We want to thank you for the support that you provide. And also we want to thank those enrollers, the day-to-day community partners, navigators that are always supporting Cover California. And to the left, you see the chart of the numbers that are comparing. In Region 17, comparing to all of the different regions, and that totals to 173,388. I know we don't have enough time, but I just wanted to share some of the things that we have through our Navigator program. This past year in 21 and 22, we had navigators, and in the Inland Empire, we had lead entities that were granted funding to provide enrollments in the Inland Empire. And we also have sub-entities under those Inland Empire or other regions in California that provided those services. And that is also another layer of enrollment that we provide in the Inland Empire. And as you see, the figure of the enrollments, funding enrollment was 275,000 in the Inland Empire, which is very generous. Remember, if those of you, some people have asked me, why is it LA has the large number of funding? Well, because they have over, 10 million people. And Inland Empire, we have about 4 million people. So also what I wanted to tell you is that marketing is one of the tools that California uses statewide to be able to support the enrollments and to support increased enrollments, provide visibility, and be able to provide all the resources necessary to the community, to the enrollers, to partners so that they can support enrollments. So let me share very quickly with you about our campaign. And we had in 2021, when we close open enrollment, we have various ways in how we provided this particular effort that help increase enrollments. Statewide, the effort in terms of the statewide enrollments was very diverse. In California, it included outreach to the Hispanics, to the Black African American community, the Asian Pacific Islander, and the LGBTQ community. The total campaign reached out to approximately about 98% of all California's adults between ages 25 and 64, about 30 different times. It was a robust media campaign that makes reaching consumers at home, online, and on the continuous tailored outreach on renewal to members and so that they can complete the enrollment process. We use TV, radio presence, including TV ads and top ranking media's advertisements such as Rams versus the 49ers, NFL game, and in key markets that were supplemented with the social media, highlighting the game as an important way of coverage. Digital media, many different outlets to be able to come to the finish line, which was the end of January 31st, so people get the enrollment. We not only reach a statewide various communities, including the API, the Spanish media coverage, but also many different groups of diverse populations that were able to penetrate the ears of individuals that needed to complete their enrollment. For Cover California, reaching to diverse communities throughout ethnic media groups has been very impactful, very important, and it has helped us make sure that all of those modes of communication to the community continues during special enrollment. What is special enrollment? Special enrollment is the phase that Cover California enrolls between February and June of this year. And when the individuals qualify for a special life-changing event. During this qualified life-changing event, individuals are able to hear through the media the different ways in how they have to build, understand what is a qualifying life event. So we try to motivate the individuals through the media and inform and remind everybody There was a budget that will be spent, which is $3 million between February and January 30th, targeting again individuals ages 25 to 64. And various different segments of the population that live in California. We're we're a multi-ethnic community in California, so we're trying to target everyone statewide, using various different modes and platforms through SCP, using media, audios, and media banners, digital advertisement, radio, etc. All of these campaigns are social campaigns that will increase and help us support the message that we're sending. I know that last year we had a great increase of enrollments because of the American Rescue Plan during 2021 now and 2020. Now during 2022, there's the California credit that consumers will be receiving, and some consumers can pay as little as $10 a month for their premiums. In some cases, $1, in some cases, $0, depending on the income of the individual. So we're trying to promote all of those types of special enrollments for individuals that qualify. Those are the ones that are qualifying under a qualifying life event. And it's going to be promoting in English, Spanish, Chinese, Korean, Vietnamese, and updating the information to all the individuals. We are also providing flyers and all kinds of modes to be able to increase that campaign.
Hey, Edith, we are going to have to get it wrapped up if you don't mind. We've got about 30 more seconds.
That is correct. And that is fine. I just wanted to thank everybody for the great support for the accomplishments that Covered California has had so far is due to the support and the partnership of all the enrollers, all of the community partners. Thank you very much.
Thank you, Edith. That was extremely interesting. I think that the breakdown. Thank you. That was really, really fascinating. Okay, well, we are just about out of time, but first of all, I've had a couple of questions. Are we going to be able to distribute these slide decks? And so I don't know if all four of you are amenable to that. If so, we're going to connect with you offline, and if you are interested or okay with sharing, then we will do that on behalf of the Ieci and the Medical Society. We'll send out what we're able to. Okay, so we have your email addresses, and we will do that with permission from our speakers. So thank you. I want to thank Iehp for your very generous sponsorship. We just so appreciate the support and allowing us to continue this work of the Ieci and just allowing the initiative and the collaborative to thrive. So thank you very much. You guys are awesome. And that leads me into thanking our wonderful speakers, Shelly LaMaster with Iehp, Hanna Kim and Nadine Khan with Molina Healthcare, and of course, Edith Laura Trad with Covered California. So our next health education forum will be May 3rd, and that will be Mental Health Awareness Month. So we'll have a mental health related topic. That should be very, very interesting. And we just want to thank everyone for all you guys do every single day. You know, you're really making the quality of life better for folks here in Southern California, and you're really ensuring the safety net for these people who really, really need it. So we thank you for that. And please check our Ieci Facebook page every so often for announcements. And if any of you have announcements that you would like us to make that pertain to this topic or any of these related topics, please email them to myself or Victoria or whoever, and we will get them posted on the Ieci Facebook page. So thank you, everyone. Have a lovely month of March, and we will see you all soon. All right. Thanks so much, everyone.
Thank you.
Okay.